Hello, this is Dr. Dimitrios Kostopoulos, and this is another episode of the podcast Precision in Clinical Practice, Boosting Profits and Patient Outcomes with Diagnostics. And today we have put together for you a very, very interesting podcast that promises to provide you with gems, ideas, and tips that can take your clinical practice to the next level. I hope you enjoy it. Let's listen to it. All right. Hello, everyone. This is the PT Innovation 2024 webinar and the Precision in Clinical Practice podcast. I'm Dr. Dimitrios Kostopoulos, and I welcome you all to this event today. The topic I have decided to bring to you today is very interesting. It's about navigating reimbursement pressures and strategies for thriving in today's healthcare landscape. So, what is my purpose in today's webinar and podcast? My purpose is to discuss a little bit of what are these reimbursement pressures, especially in the field of physical therapy? Where are they coming from? What is the reason we have these measures? And what are some of the ways that we can navigate our practices so that we can withstand these pressures and push through and move forward, creating more robust, financially stable, and successful practices. So it's interesting because earlier today I had a clinical presentation. I was invited to speak on tissue healing in cases of where implementation of dry needling with direct current is applied and how tissue healing will work on them. So, and in that presentation, at some point, I mentioned that there are physical therapy approaches, physical therapy techniques that can be extremely effective and can save significant money to the healthcare system, help patients recover very fast from injury, faster, definitely, than if patients go through the rigmarole of the medical system with MRIs and this and that and the other before they get to actually see a physical therapist that can effectively identify and treat their problem. But what's going on with the healthcare system that promotes actions and interventions that are very expensive? Okay, so I'm going to show you this for a moment, and I'm gonna for those of you who are watching, I'm going to draw this. For those of you who are attending, listening to the podcast, I'll describe it as best as I can. So now let's suppose that a patient A has an incident, and for that episode, there is $1,000 that will be spent to help that patient's situation, all right, and restore the function on that patient. Now, this patient, the premium, the insurance premium that that patient pays or the employer pays is, let's say $10,000 a year. The way premiums are right now, it's very realistic what I'm putting here. It's about, what, $750 a month, $800 a month, something like that. Very realistic. So now, what is the maximum profit that an insurance carrier is allowed to have from this? Yes, you heard me right. I'm saying allowed to have, because after the implementation of the Affordable Care Act, insurance carriers are allowed to have a maximum profit of 20% of what is being produced or what is being collected from premiums. The remaining 80% is supposed to be used for medical care. So out of this $10,000, the maximum profit that an insurance carrier can possibly make is $2,000. Now, these insurance companies, of course, they have boards of directors, and what they want them to do is they want them to make more profits. So let's take scenario B now. How this insurance will make more profit? The way the insurance can make more profit is by increasing their premiums. They have to increase the premium, let's say, to $14,000 a year instead of $10,000 a year. So the 20% of that will be now $2,800 instead of $2,000 from this specific case. Remember, the insurance has to spend 80% of this $14,000 in medical care. So this insurance prefers to engage in services such as expensive MRIs, opioid medications, anything that will increase a bit more that spend in order to increase the premium that leads to a higher profit for them. And now you're going to tell me, well, why they don't pay more for physical therapy, but they pay less? Well, it is a misnomer to consider that they pay less for physical therapy. Actually, they don't pay less for physical therapy. Maybe they pay less for private practice physical therapy, but I promise you that at the same time that you in your private practice, you spend 45 minutes with that patient, and in that 45 minutes that you bust your chops, you are making, I don't know, $85, $90, whatever you're making. For that same exact time, for that same exact service, when the patient receives that service in an outpatient, hospital-based outpatient facility, that facility for that same service is going to make in excess of $200, $200, $250, $300. And actually, what I'm telling you right now, it is not any secret. There are websites where you can go and you can check how much money a local hospital or any other organization, large organization around your practice is making for every CPT code that you can bill. There are websites out there that you can go and search this information. So this is very interesting because it is common knowledge at those levels of powerful centers of healthcare where they are able to lobby out there, to be able to achieve much higher reimbursement rates from insurance carriers than what you as a physical therapy provider in private practice can achieve. So now let's go then back into what we were discussing. Unfortunately, the system, it is not fair. Um, and we, as private practitioners, we have some options, like the same options that we have in every situation in life. One option is when you have a problem, a challenge in front of you, to totally ignore it. But if you totally ignore it, you succumb to the problem. Try to avoid it. Well, if you avoid it, it might get you somewhere, but you also have to attack it. You have to attack it, look at it as a situation, innovate, and move forward. So, and we see that the most successful practices do innovate. Actually, Dan, I know that you are on your way actually to the Breakthrough Conference, but you've been speaking to a ton of therapists out there. What are like the three top problems that therapists in private practice are indicating that they have right now?
Yeah, so definitely I've been talking to a lot of private practices. Interesting, even some that are late in their careers that are dealing with the fact that their practice is not worth much. Like this one practice in Santa Fe, New Mexico, she wants to exit in about 2 years. She went to a broker. Broker looked at her financials and said, "Your practice isn't worth that much." Spoke to another guy in Long Island. He's been in practice for over 30 years. Great guy, 8 grandkids. He works 60 hours a week. It's him in a PTA, and he can't afford to even bring in another PT. So he, after 30 years, is still working 60 hours a week. I thought that was amazing. So I think the big challenge, the number one challenge private practice owners are faced with is they're working harder than ever for less and less money. And their profits are going down. The value of the practice is going down. And it's the number one source of frustration and stress and trying to figure that out. The other issue is hiring therapists. Private practice owners, a therapist will resign, or the one guy I spoke to today that just joined us, he was stressed because he hired a PT who was supposed to start like any day now. He opened up his second clinic, and the PT decided not to take the job last minute, went somewhere else for more money. So the second issue is PTs cannot recruit and retain PTs to the level that they need to so they can scale their business and make money, and also have the business actually work for them, not them working in the business, which is extremely stressful. A third issue, I don't know. I would say those are probably the two biggest things that I am dealing with when I talk to private practice owners that are trying to find a way out, trying to find a way to handle it.
So essentially, reimbursement,
Recruiting,
recruiting,
staffing.
staffing, and I would say the reimbursement pressure leads to, of course, low profitability. So I would put as a separate category, which is a sequence, of course, as a result of the pressures in reimbursement, the lower profitability, low EBITDAs,
Yep.
and difficulties for them to have a good exit strategy.
Yep.
So yeah, definitely, I can see that. So now the physical therapists look at solutions to these problems, and um, some of the solutions are, or the easiest solution that somebody can think of is, okay, I'm going to get more patients. I'm going to get more volume, more volume, more volume. So, and I get that. All right. I totally get that as a viewpoint because, and I'm going to share my screen again here to show something else in this side at this time. If you have here your revenue which I'm going to put it in green, and your revenue as you increase your number of patients also increases. And then if you have your expenses, right, which expenses at some point, because you have fixed and variable expenses, your fixed expenses will remain relatively the same. The theory here says that, okay, what is this? This is your break-even point. You started, sorry, let me use a different color. Your break-even point is here. You started with higher expenses than you were bringing income because you were starting. At some point, as you were expanding, your income becomes more, your expenses, some of them remain the same. You have, of course, your variable expenses that also increase, and in some capacity, you end up having a profit margin here. Now, maybe my red line is not the best here drawn because I didn't factor enough for the variable expenses that go up as you increase your business.
Right.
But the interesting thing is that right now, and according to the KPI studies of PPSA PTA, profit margins are hovering around 8 to 10% at the most. Most practices are around 8% profit margin. And 8% profit margin is a very dangerous point for someone to be at. You know why? Because the moment you receive from an insurance carrier, as many providers here in New York received from a large insurance carrier, I cannot, for obvious reasons, I cannot share the name of the insurance carrier, but private practitioners received a letter that said, hey, yeah, we know you were making $85, $90 effective June 1st. We're reducing this down to $50 to $55 per session, flat fee, depending on what the sub plan is. All right. I don't know if I have still in the call here my friend Dan, but he knows, Dan Vapne, I mean, but he knows very, very well what I'm talking about here because he's in New York and he's dealing with this situation here. But so you get a reduction like this, or you get another threat from Medicare, and what happens to that 8%? Unless you run a practice that has a profit margin at least 15%, any other number below that figure can create tremendous vulnerability in the practice. So then the idea is, what strategies can someone implement to reach the level of 15% plus, okay, in terms of profit margin? And when I'm saying 15%, I'm not talking in that 15% for you to include or not get paid for the work that you do in your clinic. You have to deduct your salary from the overall. You have to include as expense your salary also, at least for the work that you do. So that needs to be included. I'm talking about the clear, clean net profit of the practice. It has to be greater than 15% to safeguard your practice. So what are then traditional approaches that physical therapists in private practice have implemented? The number one thing that has happened, guys, and if you have participated, at CSM or at the private practice section events, you know what is the number one thing that is promoted: cash-based programs. This is the number one thing that is promoted, right? Bringing into the practice cash-based programs. And I'll tell you, cash-based programs, and I'll mention some of those, can be okay, all right? But they are, number one, very difficult to implement because essentially, unless you are a solo practitioner, you are the only one, and you, through the years, have become also a good salesperson now to sell that cash-based service, it's great. But if you are not there, if you are not just a private, just a solo practitioner, but you have several other staff members, you have essentially to train every single person to become kind of a salesperson to be able to sell these services to others. Now, what are some of these cash-based services? Many people bring vitamin supplements into their practice, which is a very challenging thing to do because you have to stock inventory unless you have a subscription program. And how much they make perhaps per month per patient, something like $6 or $7. So you are talking about minuscule amounts. They bring in massage services, but they have to pay a massage therapist for that or a physical therapist for providing that. Wellness programs, again, how much would you charge for that massage session? Or how much are you going to charge for that wellness session? Are you going to charge $75? Are you going to charge $80? Fantastic. Then you paid your therapist who is going to do that $50, $55, $60 sometimes. If somebody will spend a full hour to massage someone, what is your profit margin? You're going to make $10, $15 per session, $20 in the best case scenario. How many of these you're going to be able to sell in a month? So then I find that cash-based programs present two major challenges: the ability to sell them and the actual percentage of profit that you make from each service that you sell. That is not significant. Okay. So then we go from programs that you have to sell to a patient to programs that can benefit the patient, and you don't really have to sell them because insurance reimburses for them. So let's look at that. So unless anybody can tell me differently or has heard about something that I have not in the many, many years that I have searched this, essentially, in the universe of CPT codes that a physical therapist can bill, the only addition to the CPT codes that a physical therapist can bill above and beyond straight physical therapy and get paid by insurance are electromyography, musculoskeletal ultrasound, evoked potential testing, and vestibular testing. Those are essentially the four type of CPT codes that I have found through the years that somebody can bill above and beyond straight physical therapy to get paid by insurance. So now let's take the example that I was giving before from a physical therapy patient. According to the PPSAPTA KPA numbers, 1 hour of physical therapy will produce $97. I'm not saying that you make $97 per session in your practice. I'm saying the national average. Those who get treated in Alaska, in California, in New York, in Louisiana, in Florida, in Texas, in Massachusetts. So $97 per PT session is the national average for a physical therapy session. So what is now the national average number of sessions that a patient will receive? Anybody has an idea? What's the national average?
11?
12.
12.
12, actually. It went up a little bit.
Yeah.
I guess they try through increasing the number of sessions to make a bit more. So then the episode value, the episode patient value is $1,164 for that patient. Okay? So this patient stayed with you, let's say 2 to 3 times a week. They stayed with you for a period of 6 weeks, 8 weeks, and they got you got $1,164. Right. Let's try to increase this by implementing different services. So I'm going to just do 2 services. I'm going to give the scenario of wellness or massage. So we got that patient, or stretching, let's say stretch lab like activity. So we get this patient in, the patient is with us, let's say 6 weeks. We put that patient for 6 sessions, right? And we're going to get $70 per section. Good. So we made in 6 weeks $420. All right? Let's look at our expense now here. So we know nationally that out of $1,164, 90% of that, or 92% of that, is going to go to pay expenses. So $1,047 will pay expense for PT. So from the PT, you're going to make from that patient $116 profit. That's your profit here. I'm going to take the second scenario. You charge the patient $70 for massage or wellness session or stretching session for 6 sessions. You got $420. You're going to pay that therapist, that whoever does the work, at least $50-$55. I'm going to say, let me make it easy. Let me say that you paid them $50. So you paid $300. So you manage now to have $120 profit out of 6 hours that somebody spent with that patient. You made another 120. So you did your PT, 12 sessions, you managed to get $116 of profit. You added some cash-based program with whatever it is, laser, stretching, massage, wellness. You made another $120 after spending 6 hours. Now let's take right here the option of an insurance-based program where that patient, appropriate type of patient, does an EMG with neuro ultrasound. That takes an hour. In the same hour, the EMG will reimburse national average $500. The ultrasound, national average $200. So in that 1 hour, you're going to bring in $700. How many sessions? One, in one session. So you brought additional revenue in one session, $700. What is your expense? Let's say between your therapist that you're going to pay them very, very well, equipment, whatever else. Let's say you have an expense of $150, $200, okay, which I'm quoting way, way too much. So you end up having $500 profit after this 1 hour that you spend with that patient doing a diagnostic test, and you got the money from the insurance, not directly from the patient. So there is a tremendous, tremendous difference on the financial front, and this is what I decided to talk about tonight. I mean, I can have many, many lectures about the clinical benefit, but looking a bit and contrasting what a cash-based program can bring financially into a practice versus an insurance-based, insurance-paid diagnostic testing. It is day and night. It would take you at least 4 patients to see the profitability from one patient in 1 hour. It would take you 4 patients, 12 sessions, each of them, to have a profit of $116. Okay, no, I'm sorry, $116 per patient. 4 patients will give you about $500, which is the profit you'll make from one patient in 1 hour with EMG and MSK ultrasound. So that's pretty interesting, pretty interesting data and realization.
Hey, Dimi, do you want to share even on the opportunity of a pure cash-based diagnostics, providing it in a doctor's office where they bill the insurance carrier and they're paying the provider like $250 an hour?
Sure. So another possibility here, when you put in a diagnostic program into your practice, is to aside from performing the diagnostics into your office, you can perform them, let's say, in another provider's office, in a physician, chiropractor, podiatrist office, any medical center, any other provider. So you're going to make, let's say, you work for 8 hours. So let's say you're going to see 8 patients, and you are charging the facility for $250 per patient that you see. So in 8 hours, essentially, you're going to charge the facility $2,000 for these 8 hours. The facility, of course, or the physician will bill the insurance carrier, and they're going to make significant dollars themselves also. So in this case, what is your cost? You're going to have to pay the salary of your physical therapist and your equipment expense. So what is that expense? Even if you pay your physical therapist very, very well, very good money, in the top case scenario, with all expense, is going to cost you $800 for the day. So you're going to make $1,200 from that therapist in one day. So if you had one therapist doing this activity once, if you had one therapist who was doing this activity 5 days a week, that is $6,000 for the week, $24,000 for the month, and more than $250,000 for the year. Just from one therapist doing this, not even inside the physical therapy office,
Yeah.
doing it outside in independent locations.
Yeah, and then from my viewpoint too, that's a pretty significant cash paying business. Pays a lot more than laser or massage or the other cash based businesses practices do. That you can make a big splash with that. And then the other thing is you're inside a physician's office that might be referring you physical therapy patients. You're providing that physician with a significant income stream. Where are they going to send their patients for therapy? you know, it's significant.
And can you just talk a little bit about in your experience how putting diagnostics increase the value actually of your practice?
Yeah, I kind of lost for a second there, but yeah, in terms of just my experience, we put diagnostics in our practice in 2013. And really, we did it back then purely, the primary motive was raising the autonomy level of my therapist, improving the ability to make a diagnosis, give these therapists the ability to play in the sandbox that only neurologists and physiatrists were playing in, and just give them more opportunity. And that was the primary purpose then. Um, I didn't know 7 years later when I went to sell my practice and the value of diagnostics and a strategic buyer had in that. And when we sold the practice, the EBITDA was extremely strong, and diagnostics played a significant role in that. But the strategic partner saw how diversified we were, that we had exclusivity in our entire town. We were the only ones doing diagnostics. My competitors couldn't. So the value was huge for a buyer. And we got a 9 multiple when I sold the company. And I really truly believe that diagnostics played a significant factor in that. And especially today, looking at what's happening in reimbursements, if I was a buyer, I would absolutely love the idea that a private practice had diagnostics and generating that kind of income and sophisticating their practice to that level.
Cool. And I don't want to end tonight's conversation without adding that aside from looking at innovation and bringing services, advocacy for higher reimbursements is also very important.
Yeah.
Physical therapists and other healthcare providers getting together, forming groups and organizations where legally and collectively they can work together in advocating higher reimbursements and negotiating higher reimbursements. I think it is a very important path. You see, you cannot just have one strategy, one area only. You have to take all the possibilities, your entire arsenal of possibilities, and implement it, right? I mean, I'll tell you, in our practices in New York, we have 3 types of physical therapists. We have physical therapists who do only PT. We have physical therapists who do only diagnostic testing. We have physical therapists who do hybrid, half PT, half diagnostics. So we provide, we have a very we have developed a very robust business in diagnostics. In other words, what I mean when I'm saying robust, I mean that what we bring as income from our diagnostic business, despite the fact is smaller than our multi-year developed physical therapy business, our diagnostic business brings equal income with our physical therapy business. But there you see the disparity. Despite the fact the diagnostic business and physical therapy business, they bring the same revenue in total, the diagnostic business profit margin is much higher compared to the physical therapy profit margin, if you look at them in isolation, right? So, and of course, do we have cash-based programs also? Of course we do. We have some cash-based programs also into the office, And we have those programs that would truly benefit the patient. But our core, looking outside of the box, innovation program, um, um, moving ahead from our competition, our program that creates our robust EBITDA is our diagnostic testing program in that part of the business. Let me see, there were some questions. There is a question if physiatrists or neurologists push back with having us play in their sandbox. Here is what I'm going to say. If you do this only with the intention to make money and you are not producing a quality product, then everybody will push you back. I'll push you back. Because the primary purpose for doing this is and should be to help the patients. And as a consequence to that is that you are making significant higher reimbursements and significant additional revenues and profits. Now, in our program, first of all, I have to say that our organization in New York, I know the same, Dan, was for your organization in Florida before you moved your exit strategy. And the people associated with us, with HUDs, the caliber of the work that we provide when we do testing is such that is being recognized by large hospital organizations, medical centers, and physicians who are sending patients to us because they know of the quality of the work that we do. In some cases, they send us patients. We get sometimes referrals from neurologists of cases that they would not do. Okay?
Yeah.
Not all neurologists would do pudendal nerve and other areas of the body that are more sensitive to test. But we do. Also, remember that the way you implement this program is not only by you doing it on your patients and you billing only, but you can offer this as a service to those neurologists, to those physiatrists, to in primary care, internal medicine, family practice, orthopedic offices, medical centers. You offer it as a service where they can also make revenue from those services, and then you can reap also the clinical and financial benefit. Now,
Denny, can I speak to that too for a second?
Sure. Go ahead.
So, Brian, just to speak to that, also, over the years, we respected certain referral sources. Like this one neurologist said, look, I know you're doing diagnostics, but I'd rather you not do them on my patients. No problem. So we didn't do that. And I'm a firm believer there are so many doctors out there that if Dr. A doesn't want us to do that on their patients, no problem. We'll go to the other 5,000 doctors in our community and promote our services. And I really never wanted to have my practice dictated by a physician who wasn't happy with the service that I performed. And quite honestly, somewhat better in many cases than what they do, given the level of the residency program. And we just decided to continue to flourish, expand it, and grow it, and didn't really put too much attention on that one doctor that might not want us to do a diagnostic test. And then the other day, I had a call with a neurologist that he has a neurology practice and a PT practice. He wants us to train his PT to do the diagnostics because he doesn't want to be bothered doing the test for an hour. He loves the idea that his PT down the hall can do the diagnostics and he can do something else, maybe do other type of medicine or golf, So I think more and more physicians, they see the value of what we can provide, and you'll be shocked at how significant that is.
I just want to read you a couple of segments. I'm not going to put it on the screen. This is from our marketing person on Wednesday, May 8th. Oh my God, he's typing late at night, 11:23 p.m., he wrote. So he says, "Hi team, a great story from today. Make sure you read the success at the bottom in blue," he says. Okay, Eric and I set up a table on April 17 at the blah, blah, blah health fair in that area. Dr. So-and-so stopped by our table and we chatted for a bit. He owns and works at a beautiful, large urgent care center in that area and asked me to stop by sometime. I stopped by today to meet him. Very nice and large urgent care facility in a large shopping center with a Target and another physical therapy organization nearby. And then he says he brought me into his office, blah, blah, blah. He was impressed about our diagnostic services and which other clinics do not offer. He was very interested in musculoskeletal ultrasound and EMGs and posted all of our info on his wall in his office. He has a lot of diabetic patients, including himself. He brought his staff into his office to make sure that everyone bookmarks our patient referral landing page on their computers. About 2 hours after my visit, I started seeing landing page appointment requests, one after another, from doctor whatever. Totals for today, that office, 2 patients for EMG, the other office, 3 patients for EMG, and 1 for MSK ultrasound. So, I mean, this is pretty much the kind of success stories that we see time after time after time. So, it's absolutely awesome. All right. Are there any other questions from anyone who is attending live here? So if not, I would like to mention that please make absolutely certain that you join us in the next event, in the next webinar and podcast, where we're going to talk about a very important topic. It's going to be about unlocking profit potential, maximizing EBITDA for practice success. And
you see that? There's one question there, Tim. You see that?
Okay. We recently established a relationship with a very large pain medicine group that sees 70% workers' comp. They sent us 4 referrals yesterday, 1 week after our initial meeting. When I reached out to the case manager to get authorization for the EMG and CS, she told me it wasn't approved, and if it was, it wasn't approved, and if it was,
you have to be a doctor.
You have to be a medical doctor. Any suggestions for getting around this? So you will have to look, Matt, at the specific reason they are saying that. If there is something that they have in their policy, and this is the reason they do that, we can, part of the as part of the revenue cycle process that we have, we recommend some steps that you can take about that. I would strongly suggest that you bring it up to Joanne, and then she can reach out to me and we can look a little bit more into that and see how we can help you on this. Okay?
To Joanne, actually, so she should be in touch with you regarding that.
I reached out to Joanne today, actually, so she should be
Okay.
getting in touch with you.
Cool. Okay. Good. So
I responded with letting her know, mentioning that it's part of our Practice Act and that it's accepted by Medicare and blah blah blah. I know that in Illinois, like the work comp laws in Illinois don't allow the case managers to direct care, so patients can go to any provider they want.
good.
But I don't know, if they can distinguish between something like this with a medical doctor versus a PT. So I'd have to find that out.
So yeah, we'll help you on that, and we're going to check from our side also. And of course, I mean, if there is a legal violation that they have, or this specific case manager is working then we're going to refer this to the state insurance department.
Yeah.
In the state.
I mean, it was a typical case manager response, feeling in and liking to tell people no.
Of course.
But we just established this relationship, and considering there's going to be a lot of these cases, it'd be nice to see if there's a way around it if this comes up again. Yeah,
of course, absolutely. So we'll definitely look into that. Okay, any other questions from anyone? Dan, do you want to just put some information on how people can reach out to you? You can always reach out to www.handsondiagnostics.com, and also if you want, you can reach directly Dan Sage at 561-441-5744. He put his number, or email to him at dan@iHUDS.com.
Yeah. I would. If anyone's interested, I'm more than happy to help navigate it with you and see if it's a good fit. I mean, I'm excited. We signed up 4 partners in less than 4 weeks, so more and more private practice owners are looking ahead, forward thinking, how to navigate, what's happening to us in private practice, and I'm excited, and I'd love to talk to anybody.
Awesome.
Yeah.
All right. Thank you all. That's it for this episode of PT Innovation 2024 and Precision in Clinical Practice podcast. See you all next time. Good night.
Take care.
All right. That's it for today. I hope you enjoyed today's podcast and that you got some gems, ideas, and tips that you can use in your clinical practice that can create a difference in the way you practice and the way you profit. I hope to see you all next week. Until then, have a wonderful week.